Today we're with Dr. Alison Peck, friend and colleague of mine for the last 10 years here at HRC in Encino. Dr. Peck, welcome.
Thank you.
Thanks for making the time. How do you approach the patient with secondary infertility?
The patient with secondary infertility is a bit different than a patient with primary infertility, meaning that they've already been successful before and they've been able to get pregnant and ideally have a baby, and now they're back and they're realizing they've been struggling. And so it's really important to get a great history from them with whatever previous records they may have had, anything that happened in their previous pregnancy, and anything that's happened in their life since the last time they were able to get pregnant. Starting with a history is always most important. And second is to do an evaluation by a pelvic ultrasound and to look around and see if there's anything new in the pelvis that could be impacting their chances of getting pregnant right now, as well as getting a history from the partner and seeing if anything's changed in the partner's life as well that's providing the sperm.
What's your take on patients' lifestyle?
The sooner they can see one of us and talk about their changes in their medical history, any new medical diagnoses, any new surgeries, any new changes in their lifestyle, any type of toxic exposures. But most of all, we really want to get down to testing them.
What are some of the common typical tests that you'll order? Do you treat that patient all different?
Overall, the testing for primary and secondary infertility is similar. We always will start with how fertile a woman is at this stage of her life, which usually includes blood tests and ultrasound at or around the period, which gives us a wealth of hormonal information about their egg supply and how much we can access and use that egg supply to help them get pregnant with our different fertility treatments. And then we're assessing their pelvis with either ultrasounds, HSGs, water sonograms, sometimes MRI to see if they've developed some type of new lesion in their uterus or their ovary or in their fallopian tubes that could be impacting the egg and sperm from beating inside their pelvic cavity. And then we want to check the male partner as well to make sure his semen analysis hasn't changed.
What are some changes that are pretty typical?
I think the number one change is in ovarian reserve and the natural decrease in egg supply and quality as women's bodies get older. I'd say the second most common thing I see is what's happening in their pelvis, so some type of anatomical change. Some of these patients will have gotten exposed to an infection in the last couple of years that would have increased their chance of having tubal problems or pelvic problems that they're unaware of. A lot of things that happen at or around delivery can have an impact on how the uterus goes back to it.
What's your experience with fibroids in our patient population?
I'd say it's pretty common because most women, as they get older, the fibroids develop unbeknownst to them. So many times we're the ones actually making the diagnosis of fibroids, and patients won't even know. We find these usually on a pelvic ultrasound. The majority of the time, if the fibroids are small and they're not penetrating the inner part of the cavity, we like to avoid them to prevent them from having unnecessary surgery on their uterus. But if the fibroids are in the space where the embryo has to grow and develop, then it becomes very important to have that taken care of and removed before they get pregnant. It's an important population because those patients are also getting older and going off having fibroid surgery can take them 3 months, sometimes 6 months to recover. So that's a population where we would usually want to save some of their eggs before they go have any major surgery. And sometimes we'll be in communication with the treating obstetrician because our job is to help them get pregnant and watch them through the first trimester.
How do you counsel your patient on diets and exercise and supplements and vitamins?
I believe in a very holistic approach to medicine, especially in fertility. And I believe that between diet, exercise, and all the things you mentioned, everybody should be paying attention to what they're putting in their bodies and how often they're moving. I don't think there's a perfect diet for fertility. I think patients should be on prenatal vitamins with some version of folate or folic acid. I think vitamin D levels should be up to date. Thyroid function should be working well. And I think people should pay attention to what they're putting on their skin and what they're putting on their face and how they're using their products at home, cleaning the house, and just notice that there are a lot of toxic things in our environment and we want to steer clear from those things.
How do you tell them their prognosis? You're at the end of the visit and you've done the testing. What do you tell them about prognosis?
I like to be very enthusiastic in patients that have secondary infertility and honest at the same time because they have been able to achieve a pregnancy. So I feel like they have a good chance of achieving another pregnancy. So much of what I say prognostically and quoting in numbers will depend on what we find in the ovarian testing, the pelvic testing, the sperm analysis, and it really depends. Obviously, the younger the patient is, the better, the higher the prognosis, but overall, these patients have a very good prognosis, and I would encourage them to come sooner than later so they could take advantage of their fertility and their health.
Please come see Dr. Peck. She's in our Encino office, West LA, and Westlake Village. Thanks very much.
Thank you.